outside
Hello,
of the.
again. I will start. Hello, my colleague. This is our first session in gynecology Viva hot seat cases. Let's start with
Mm.
our first candidate. This is a 35-year-old female patient presented with infertility. Let's start with this one.
Okay, okay. So I've been provided with the MRI scan of the pelvis in T2 weighted axial images. Uh,
Mm-hmm.
here I notice the striking abnormality is there are two cystic lesions on the anterior aspect of the pelvis. Uh,
Okay.
the which are of differential intensity. The right one is of the intermediate intensity, and the left side I see it is of the low intensity. I would scroll in the cranial. I would like to see scroll and see in the sagittal images to see the anatomical localization of the cystic lesions. Okay, yeah. This appears to the right side one. Right side the cystic lesion is homogeneous, and it appears to be in continuity with the fundus of the uterus. Uh, then
Yes, yes. What else?
yes, yeah.
Look at the
Yeah, yeah.
this
Yeah,
axial.
yeah. Yeah, yeah. In
Yes.
the Excel, I see that the both the uterus it has two separate cavities with a septa extending up to the cervix. So this is a
Okay.
so I would like to see the lower end of the separation, and so it is two two separate uterine cavities. So uh, it is extending up to the lower cervix. Can I scroll down, sir? More. So, and there, okay. So,
What's your diagnosis? Give
this,
me give
yeah, yes, sir.
me
Yeah, yeah,
a
yes,
little
yeah.
bit of
So,
mm, give me
so
any
this is
professional diagnosis.
septate cells. Yes, sir.
Okay,
Septate uterus. This
okay.
is the concern.
And what
And
about
with
this?
what about these two areas in the along the fundus? Uh, I'm thinking that probably they are. I could not see the ovary. I'd like to see the ovary separately. I am not able to localize the ovary. So I presume that these are heterogeneous, cystic lesions of the ovary on both sides, which could be hemorrhagic types because of the differential attenuation. Uh,
What sequence do you
uh,
want?
Sir, T1 I want to see for the hemorrhage. Yeah. In T1 weighted, yeah, I can see that the both side of the adnexa has cystic lesions, which are the right side has septations within it, and they are bright on T1, and one was dark on T1, and the second was intermediate on. I mean, the left was T2 hypointense, and right was T2 intermediate. So these are in keeping with I mean hemorrhagic or endometriotic cyst because of
Eh,
the character of
one
hemorrhage.
second.
Yeah.
1 second. Hemorrhagic or endometrioma. There are a big difference, by the
Uh,
way.
yeah,
Mm.
it's different. The wall is thick wall. The lesions have the cysts have thick wall, and in the background of history of infertility, I am more in favor of thick wall because these are thick wall lesions, and so I'm in favor of endometriotic cyst.
From
However, I
the
don't.
this see, give me one
Yeah,
sign from the MRI.
okay,
Okay.
okay.
Look at
I'm
this sign.
looking for the shading. Yeah, right sided has a shading like appearance, intermediate grading of the intensity.
Okay, so
So, hmm. so that is suggests for the different stage of bleeding within the cyst. So that is the feature of a endometriotic cyst.
okay, there are another sign here.
Yeah, yeah,
Okay, so
and
you
yeah,
informed
yeah.
me, doctor, 1 second. Informed me this is a T2 shading sign. Okay, correct?
Yes, yes, yes.
What about this sign? What is this appearance?
Uh,
What does this indicate?
this some nodular areas are there within the cyst. Sir, any other sequence or can you scroll?
No, from
This,
this.
okay,
My
this
question
sign.
is very
Okay.
clear. There
Yeah,
are a
yes.
sign
Mm,
here. You should tell me, and this is a
mm,
differential sign between
mhm.
hemorrhagic cyst and endometrioma.
Okay. And, and Endometriotic. No, sir, I'm not recalling this sign.
Okay, I will tell
Mhm.
you later. Look
Yes.
here.
Yeah.
What happened here?
Okay. Yeah,
Here
the
in this
cysts are
slide.
actually oblong and extensive. Long oblong shaped cysts are their large size, superior, located anterior and superior to the fundus of uterus. Yeah, and
Okay, okay. Give me your final diagnosis, please, and the management.
so yeah, so sir, this is a case of bilateral endometriotic cyst with septate uterus. Uh, with
Yes.
septate uterus. So this is a concern for infertility for this case. So this will I will suggest for a gynecological referral and subsequent surgery may be indicated for the septate uterus. That's
Thank
one
you,
thing.
doctor.
Yeah, yeah,
Thank you, doctor, so
yeah,
much.
yeah, yeah.
Uh,
Thank you, sir.
when is your exam, doctor?
So tomorrow.
Doctor, see,
Mm,
today and
mm,
yesterday you did very well, really.
mm.
Both
Okay.
today and yesterday, this is the best
Yes.
time that
Mm,
you present the cases. So
okay.
I
Thank you.
hope I am trusting you. You
Mm,
will pass
mm,
tomorrow, inshallah, hopefully.
okay.
But
Yeah. Thank
take
you,
one
sir.
up.
Thank you so
Oh,
much.
welcome.
Mm,
Take
yes.
to advice. See, doctor,
Yeah.
this is
Yeah. Yes.
T2. When you see
Mm-hmm.
in T2, you
Mm,
pick up this one, T2 shedding
mm.
sign. What is shedding sign?
Yes.
Different
Yeah.
degree of gray.
Difference.
Different
Yes.
degree, gradual. Okay.
Mm,
So due to recurrent bleeding.
mm.
Here, T2 dark. In T1,
Okay. Yeah.
in T1, one second,
Hemophilia.
give me my opportunity. In T1, this is a high signal.
Mm,
Okay, and we should see
mm,
T1 fat set. Suppose that we see fat set and this is hemorrhage.
mhm,
When you see this
mm,
hemorrhage
mm,
completely
mhm.
dark in T2, means this is hemosiderin,
Hemophilia. Yes. Yes.
in which pathology you can see the bleeding transfer to hemosiderin in chronic bleeding.
Mm,
In chronic bleeding
yes.
is related more to endometrium. That is that is
Endometriosis.
the point. Okay.
Yes.
Thank you,
Yes.
doctor, so much. You did very well.
Mm,
This
mm.
is called when
Thank
you see both
you.
endometrioma casing each
Mm.
other.
Kiss,
This is
yes.
called
Kissing.
casing sign.
Kissing over it. Kissing over it.
Yes, excellent. Second, look. I will bring from down. Where from
Mm,
down? Look, my colleague here.
mm,
Okay, this is septated uterus. You did very well. This is not
mm,
didelphys, yeah, my colleagues. Why?
mm, mm, mm,
See here, this is one uterus. One
mm,
uterus. And the second point, this is
mm,
not muscle. This is fibrous
mm,
septum. Fibrous septum. Third, look here.
mm,
This is not
mm,
didelphys. Why? Because this is
mm,
acute angle, less than 75. The surface
mm,
here is flat or convex. So this is not didelphys. This is not bicornate. Okay,
mm,
but
mm.
look here. This is follow the rectum, please. Follow, follow,
Mhm.
follow, follow.
Okay.
See here what
Mm,
happened. The rectum
mm, mm,
and the boss ovary,
mm,
there are element. See, band of fibrosis
mm.
here.
Band of fibers.
This why? Because there are deep infiltrating endometriosis. That is
Endometriosis.
the
So,
same signs that I ask you here about. What not important
mm,
question. See here,
mm, mm,
this is abnormal, my colleague,
mm,
to see the rectum
mm,
adherent to
mm,
the ovarian endometrioma.
mm.
Like here, this is due to deep infiltrating endometrioma.
Yeah, in the
Okay?
cul-de-sac and yeah, in the cul-de-sac.
Yeah.
Yes, sir.
This is casing endometriosis,
Ovary.
okay,
Mm,
or ovary. Here, this is clover leaf
mm.
sign due to fibrosis.
Okay.
I think here also you can detect, we must look at the junctional zone. I think not second,
Mm.
not too much second here. Anyway, thank you, doctor, so much. Next candidate.
Okay. Yeah. Thank you, sir.
Yes, sir.
Welcome. Doctor, this patient, 25-year-old female patient with right lower quadrant abdominal pain increased over the past 24 hours associated with nausea. Okay? The pain is not relieved by tramadol. Can you? Yes, thank you. Scroll, doctor.
This is the contrast enhanced CT scan of the pelvis of a 25-year-old woman with lower abdominal pain for 24 hours. I'm seeing a mass lesion in the posterior to the uterus, which is heterogeneous in appearance. And I'm looking for the I can see the uterine cavity. The mass is more towards the right side with the hypodense areas suggestive of cystic area inside. And I'm trying to look for ovaries, right ovary, and not able to see separately. Ovaries, I cannot see ovaries separately. But in a 24-year-old with acute abdominal pain, I'm suspecting a torsion.
Excellent.
But in the CT scan, I'm looking for any whirlpool sign of the ovarian pedicle. Anyways, it is not a ideal modality of choice. I would also look into the ultrasound.
Okay.
And MRI will also help. But in this left side ovary and right side also, there is a doubt of some particular twisting on the right side, but I'm not confirmed in this. I'm not sure in this CT. But anyway, there is a cystic lesion in the abdominal. It appears to be in the right adnexia. I would correlate with the ultrasound to see for enlargement of the ovaries and peripheral follicles and for a whirlpool sign. And I would like to see the
one second.
coronal images also.
Yeah. See this cystic lesion. What happened at the periphery here? What's this?
Periphery, there is some follicles are there. Yes.
So,
but I'm not able to delineate which ovary and.
Okay. What? So, what is this overall?
Overall, the ovary is enlarged in size with on the right side. There's peripheral follicles are there, which are suggestive of torsion only. And clinically also it is correlating. So I will inform the findings immediately to the gynecology team and advise to do a USG correlation and also MRI if indicated.
Thank you, doctor, so much. This is a surgical emergency or gynecological emergency. What happened here, my colleague? Doctor, we can mistake this as cystadenoma. Okay, this is all right. But see, the location is very characteristic. Where is the location? Between the rectum and the uterus. Even if any cystadenoma located in this location, consider torsion.
Yes,
And suppose there are a tumor here. Okay, this ectopic or abnormal location is a very common sign of torsion. What is the signs of torsion? Number one, markedly reduced contrast like here. Second, edema. Third, and the most important, the second is the ectopic location. Very important. See? Okay, my colleague?
Yes.
This is the left one. The question here, why the ovary has some enhancement here? Why? This is torsion. Why? Because it has dual blood supply. Dual blood supply. See, here there are a good contrast here, but down, no contrast in the center. This is due to dual blood supply. Thank you, doctor, so much. Next candidate.
Yes, sir.
Hello.
Hello, sir.
Hello, Dr. Roshni.
Yes, sir.
This is 40-year-old female patient complaining of pelvic pain. Go on.
Yes, sir. I have been provided with the axial T2 MRI images of a pelvis of a lady who was presented with a complaint of pelvic pain. I'm scrolling through the images. First, I have looked through the whole set of the images. Then I will comment my finding. Okay, so here I can see that there is evidence of a multiple lesions seen within the ovary, which are giving a fluid level. Also within the both ovaries. There is a layering pattern is noted of differential intensity. The upper one are the hyperintense and the lower are the hypointense. There is also some fibrotic dark like fibrotic elements are seen which causing teething of the ovaries and also the rectum, giving a appearance of deep pelvic endometriosis.
Excellent.
I'm looking the uterus to see if there is any evidence of adenomyosis.
Okay.
The junction zone appears to be slightly irregular. However, I will also confirm on the sagittal images. As I'm thinking of endometriosis.
One
However, I
second.
will also look the T1
One second.
material.
One second.
Yes, the junction zone appears to be thickened, predominantly on the posterior aspect of the uterus. With there are some internal heterogeneous area also noted within the uterine cavity, uterine myometrium. So suggest of adenomyosis, and the teething aspect is also seen on the posterior superior aspect of the uterus, which is causing the indentation over the rectum.
What is the cutoff point measurement of the adenomyosis of the junctional zone?
It should be greater than 2 centimeter. Yeah.
How many, please?
Greater than 2 mm. Sorry. Yeah.
No.
2 centimeter.
No. 12 mm.
Okay, sorry.
12 mm. See, between 8 and 12 is borderline, but above 12 is diagnostic. Okay?
Yes.
Okay. So give me your diagnosis.
Yes. Can I see the T1 weighted images to just confirm it? Whether it is hyperintense on a T1. Otherwise, I'm sure this is like endometrial. These are the endometrioma with endometrial implant and deep pelvic endometriosis. So I will immediately convey my finding to the referral physician or refer this patient to the gynecological team for further management.
Thank you, doctor, so much. This is a case of adenomyosis here, posterior. Okay. Second point, see my colleague here, the fluid flow levels of this ovarian cystis. What happened here? This low level dark signal is a hemosiderin. This is very important. This is denoting a chronic hemorrhage. Here also, this is T1, bright, almost a bright signal. And look here, this is the clover leaf here, here. Okay, this is very important, my colleague. This is very important. Okay, and there are this one, I think this is the uterosacral ligament. See, second, this one of the commonest anatomical structures that affected by deep infiltrating endometriosis. Thank you, Dr. Roshni, so much.
Thank you.
Next candidate.
Okay, doc.
Next candidate.
Yes, doc, I'm here.
Raise your voice, please.
Okay. Can you hear me now?
No.
Just 1 second.
Your voice is very weak.
Okay. Could you hear me now?
Yeah,
Could
much
you hear
better.
me now? Okay.
Much better. But see, there are some echo in my voice.
Okay, just 1 second. Oh. Okay. Could you hear me now? Well?
Yeah, better.
Okay.
See, there are echo of my voice. It looks you open The session from two devices.
It's from two devices, but I closed already one. I closed
No,
the
no.
signal.
No. See? I listen my voice twice.
No, it's only one. It's only one device that working because the second one has a problem even with the sound. It's
Okay.
closed.
This is a 40-year-old female patient
Okay.
presented with. See, doctor, see, when I will mute you when I am talking. 40-year-old female patient presented with vague abdominal pain. Unmute yourself, Dr. Arwa, and go on.
Okay. I've been provided with ultrasound images for a female, 40 years old, coming with abdominal pain. I can see that there is evidence of echogenic lesion, cystic lesion with mixed echogenic content noted within the pelvis. I can see also that there is evidence of hyperechoic soft tissue lesion noted within it with heavy internal echoes and posterior acoustic enhancement. I couldn't see that there is evidence of any Doppler noted within soft tissue lesion. As this patient complaining of pain, it's not clear in which adnexus is this lesion. However, my provisional diagnosis for this is a cystic lesion noted within the pelvis with mixed echogenic content and soft tissue density with no contrast, with no Doppler suggesting that there is maybe dermoid cyst or mature cystic teratoma. I would convey my finding for the referring physician and arrange for CT to check it and confirm the diagnosis, or MRI. Okay. In MRI, I can see that this is a T2. Okay, this is a T2 axial, coronal cuts. I can see that there is evidence of the lesion noted within the left adnexa with hyperintense signal noted. I want to look for it in the T1 to know the signal intensity of it. Okay, in the T1, it appears that hypo-intense, iso-intense signal. It appears to be iso-intense signal. Okay, just I want to look for the fat sat if it's available. T1 fat sat. This is T1, sorry, this is T1 fat sat, and it shows that there is evidence of a hypointense signal noted within the lesion, suggesting that there is a fat content. In post-contrast, also, I want to be sure that there is no contrast enhancement for this lesion. Okay, there is no evidence of contrast enhancement. Sorry, this is axial T1 with no fat sat, and the lesion appear to be a hypointense signal in the T1. So again, this lesion is hypointense in T1 and isointense in T2 fat sat and hyperintense in T2. And there is evidence. I want to look for it in the post-contrast also. There is no evidence of contrast enhancement noted within this lesion. So this lesion could be a hemorrhagic cyst. But it's a hypointense in T1. So I'm really, again, no contrast enhancement. Okay. And just I want to look for if there is any, no invasion of the surrounding. Okay, no contrast enhancement. Okay, no, this is again the post-contrast fat sat, post-contrast fat sat with no contrast enhancement. No.
Doctor, at least tell me this is aggressive or not, benign or malignant. Unmute yourself, doctor.
It's not aggressive lesion.
Yes.
I am doubting between two lesions, which could be a dermoid cyst, but it's not typically with the fat signal. At the same time, it could be hemorrhagic cyst. But again, it's not typically with the signals of hemorrhage.
See, doctor, you didn't find fat, you didn't find hemorrhage, so you must exclude both this differential diagnosis. This is what else? What is the last expected differential diagnosis? Unmute yourself.
It could be serous cystadenoma.
Excellent. Thank you.
Thank you. This
Unmute yourself, doctor.
Okay, this is serous cystadenoma. I will convey my finding for the referring physician and for MDT for gynecological team for discussion and management.
Thank you, doctor, so much. Very tricky case. Very tricky. Why? This, I don't know why this nodule didn't show in at all in the MRI. Never. Nothing. Even this septation. Any clue for, I think this ultrasound not related to the MRI. Suppose this is ultrasound related to the MRI. We see the ultrasound, okay? And from the ultrasound, it looks like malignant. Then after we did the MRI, it looks like very benign. So the most reliable is the MRI. See here, in T1, no any clue, no any evidence of hemorrhage or fat or anything, just a simple cyst or a benign cystadenoma. Even here in fat sat, see doctor, this is not ISO. ISO to what? To the muscle? At least, no, this is less than, this is a hypo-intense signal in relation to the muscle or the uterus. When you are confusing in case like this, tell the examiner, oh, this is a hypo-intense lesion in comparison to the uterus or to the smooth muscle. Usually, we take the muscle, skeletal muscle as a reference. Here in the gynecology, you can take the uterus as a reference. And also it is a muscle. See, the skeletal muscle, nearly the same signal of the uterus. So this is hypo, okay? No any clue for hemorrhage or fat. No any mass, enhancing mass here at all. So we are, at least till example, this is non-aggressive uterine cystic lesion with no mass, with a smooth, very smooth thin wall. So this is a benign cystadenoma. Very tricky case. Thank you, doctor, so much. You did very well. At least a tricky case, you correct yourself, but very nice. Next candidate.
Yes, sir.
Welcome, 40-year-old female patient has a rectal bleeding. Would you request control, please?
Okay.
Go on.
All right. I'm presented with a 40 years old female patient who has a history of rectal bleeding. These are the sagittal T2-weighted images of MRI pelvis. Here I can see that there is a abnormal signal intensity mass lesion seen in the pelvis in the region of rectum and cervix, which is appearing hyperintense with internal hypointense nodularity.
Okay.
Yes, and it is extending into the cervical canal and anterior lip of the cervix. The endometrial canal appears unremarkable.
Uterine myometrium shows some focal lesions which are likely fibroid. I like to see it on the axial images as well, if available.
This is
Can
axial.
you
Take the axial.
okay. Okay. To axial, yes, so it's a T2 hyperintense mass lesion involving the rectum and predominantly with the more mass lesion, more being centered on the rectum and also involving the cervix interiorly. Um, and there is adjacent marked fat stranding in the mesorectal fat. Um, I'm looking at the bilateral ovaries, which are unremarkable. So, on the basis of hyperintense T2 hyperintense mass lesion with internal hypointensities, this could be a mucinous adenocarcinoma of rectum, which is also involving the cervix anteriorly.
Excellent.
However,
Excellent.
I'd like to see the post-contrast images as well.
Take the
Are
post
there?
contrast.
Okay. Yes, on the post-contrast images, the mass lesion is seen heterogeneously enhancing. Um, It is also involving the mesorectal fat and mesorectal fascia, and also it's involving cervix, so it's a T4 disease. I like to convey my findings to the referring clinician and will advise CT, chest, abdomen, pelvis for staging, and MDT referral and colonoscopic biopsy correlation for histopathological diagnosis.
Excellent, doctor. It was a rectal carcinoma, severe, extensive rectal carcinoma infiltrating the vagina and extend here in the vagina, causing a rectovaginal fistula. What is the staging grade for this patient?
T4A.
Okay, excellent, because it caused local invasion. Thank you, doctor, so much. Next candidate.
Thank you, doctor.
Yes, please.
Doctor, request
Yes.
control, please.
I'm sorry I couldn't do it. Can you do it for me, please?
Okay. Doctor, this is 6-year-old female patient presented with epigastric fullness and tenderness.
I have presented with CT abdomen and pelvis with without contrast, and there is mass lesions and multiple
No,
nodules
1
seen in there.
second. With oral contrast.
With oral contrast,
Correct?
no intravenous contrast.
Yes.
I have presented with multiple slices of CT abdomen. There is multiple nodularity and the mass lesion seen in the omentum. And there is a free fluid is seen in the both paracolic gutters. I couldn't see any significant lymph nodes. That could be omental caking. We're looking for ovarian tumor, pancreatic tumor, or GIT tumors.
Okay, look down. See, take the post contrast, please.
This post contrast, there is mild enhancement of this previously mentioned multiple nodules and the masses of the omentum, proving this is a mass lesion of most probably omental caking, maybe
Yes.
related to adenocarcinoma of the abdomen or pelvis. So I will review the pelvis for ovarian lesions. There is also nodules seen at the peritoneum, anterior peritoneum, at the lower peritoneal pouch. There is no significant enhanced lymph nodes. There is no sizable cystic masses or solid masses seen in the pelvis. If there is available MRI, I will asking for it, and also if there is carcinoma embryonic antigen 19 or carcinoma antigen 125.
Okay. Okay, doctor. So
After
finally,
that, aspiration and histopathology is asked, as
finally,
well as
what's your diagnosis?
There is multiple cystic lesions in the liver.
Yes.
There is intraperitoneal metastasis of unknown primary. I will ask it for a tumor marker and histological and cytology.
And look here what happened for the liver surface, please.
Liver surface showing slight scalloping at the posterior aspect and
Excellent.
vertebrate.
Excellent.
Okay, this could be
what is the cause?
mucinous.
What is
Mucinous.
mucinous?
I mean, this mucinous tumors like again like adenocarcinoma of ovarian, adenocarcinoma of pancreatic, or GIT tumor.
Okay. What is the name of this process, doctor, please? Overall. Hello?
Yes, I'm with you, but I'm
Pseudomyxoma.
peritonei. Pseudomyxoma peritonei.
What is the most common cause for pseudomyxoma peritonei in female?
In female, mucinous adenocarcinoma of ovary or rupture mucocele of appendix.
Excellent, doctor. Doctor, I think this is the first time for you with me, correct?
Yeah.
Really, I appreciate your style. Amazing. Really, you are very self-confident, you are very quiet, and you are concise. Thank you so much, doctor. Really, I'm so impressed. This is a case of metastatic right ovarian cystadenocarcinoma. Why right, not left? See, at least there are some nodule enhancement here. Sure, we need MRI to be sure of the site of everything in the ovary, but at least there are a clue here. And then see my colleagues, see my friends, as I told you before, the most common pathway of metastasis in ovarian is the peritoneum. See, extensive mental cake, incredible. Even look at the liver scalloping. Okay, doctor, if this male, what is the most common cause of this peritoneal and the liver picture in a male?
In a male, maybe testicular, Sertoli cell or something.
Again,
or pancreatic.
this is a pseudomyxoma peritonei. What is the most common cause for a male?
Mucocele for the appendix or
Excellent.
carcinoma.
Adenocarcinoma.
Base of appendix carcinoma.
Yeah, adenocarcinoma of the appendix. Whatever in the base, in the tip, but adenocarcinoma of the appendix. Thank you so much. Next candidate.
Yes, sir.
Hi.
Hi.
Could you request control, please, doctor?
No, I can't.
Okay. This is a 30-year-old female patient presented with persistent uterine bleeding after abortion, medication abortion.
So I'm provided with the multiple axial sections, CT scan post contrast of a female present with the vaginal bleeding post abortion. So I can see that pelvic, the uterus bulky. And I can see that there is a multiple tortuous vascular structure seen within the uterine myometrium.
Yes.
I have a suspicion of extravasation. There is no free fluid.
Okay, excellent. But what is this? Look
signs
again.
of hemoperitoneum.
Look again here. What is this?
Uterine artery dilated.
And?
Tortuous and
excellent.
Intramyometrial. I have suspicion of AVM. There is a nidus. Yes.
Excellent.
There is
excellent.
Tortuous vessels with the serpentine vascular structures ending into a nidus within the myometrium, and also the uterine cavity is distended, fluid filled. There is no free hemoperitoneum or free fluid. Can
Yes.
you scroll to see other? The contour is not clearly visualized to exclude any signs of rupture. Long window or scrolling, please. Distended urinary bladder, the bowel looks normal.
So what's your next step, doctor?
If there is any MRI or angio.
MRI or angio. Okay, what else?
Ultrasound.
No. See, you are okay, but what is the most important? You have a doubt about AVF.
CT angio.
Okay. Look here.
Yes, there is a nidus within the uterine cavity, supplied by the multiple dilated structure from the uterine artery and internal iliac artery.
Yes.
So this is a picture most likely suggesting AVM, and I will refer the patient
No.
to the
See.
yes.
See, not AVM. This patient just
AVF.
Yes, just
Yes.
has a portion. So they must use some instrument. Correct?
Yes, traumatic AVF.
Yes.
Yes.
This is okay.
So if
Look.
next we can embolization and interventional radiologist for embolization.
Excellent. Thank you, doctor, so much. Take care, my friends, from post any uterine procedure, and you find this abnormal tortuous vascularity, your first differential diagnosis is arteriovenous fistula until proof otherwise. How can we differentiate the arteries from veins here? Number one, look the veins here are little bit tortuous. Here, this is veins, and the diameter is larger than the arteries. Okay, my colleague. Second point, the veins has valves. Where is the valve? I think it is valve. This is a site of valve that more visible or more obvious here, by the way. Here, see? This is angiography of the internal area or the posterior branch of internal area. See here? Here, see? The valve of the veins is very clear here. Valve of vein is very clear. This, I think, this dark dots. Valve. Okay, my colleague? You are injecting artery. So, till now, arteries. Then you see a collection, a bunch of veins here. Okay, my colleague? So, this is AV fistula. Transfer to interventional radiology. I think here in this, the same seat here, they can occlude it. See here, my colleague, after occlusion. What's your opinion?
Complete obstruction of the AVM, of the AVF.
Yes, they occlude most
Yes,
of it.
there is no vascularity seen.
Okay. By the way, for rapid emergency bleeding, they can use the gel foam.
Gel foam.
Gel foam. But this is for a life saving. Thank you, doctor, so much. Next candidate.
Hi, doctor.
Hi. See, this is a male patient, but it has a very important pathology.
Okay.
40-year-old male patient presented with a swelling of the scrotum. Go on.
Okay. So I've been presented with sagittal T2 images of a male patient who have been presented with scrotal swelling. So first of all, I'm going through the images before describing them. So I can see that there is a T2 hyperintense heterogeneous structure anterior to the rectum or rectovesical pouch. So I'm thinking a line of seminal vesicles. So I will confirm these findings on axial images.
Okay, take the
So
axial
I'm
image.
checking.
Take.
Okay. So on axial images, first I'm going to my area of interest and I will check the scrotal area. So on axial images, I can see that there is a heterogeneous structure with cystic and some intermediate solid components seen in the right test phase. So as the patient is 40 years old age patient, so I'm thinking some aggressive lesion as it shows complex structure, and I cannot see any yeah, there is cystic structure surrounding the solid component, so it may be a small hydrocele which is surrounding the solid component. So as the patient is 40 years old patient, the torsion of the testes is less likely because this is usually occur in the younger age patients, but it can be a possibility. The other possibility could be I can see enlarged lymph node in the right inguinal region.
Yes.
So I will check any other sequence like restricted diffusion or DWI and coronal images if possible.
You can take C. 1 second. DWI.
Okay. So on DWI, I can see there is significant high intensity areas, so which are present within the testes and also within the lymph nodes. So I will check. I want to check the ADC of the same region.
Yes, take immediately.
Okay, so on ADC, these structures appear low intensity, so it confirms the presence of diffusion restriction. This is an aggressive looking lesion with restriction and enlarged lymph nodes. Lymphoma can be differential in this case. Other possibility of testicular tumors.
What else?
Lymphoma, germ cell tumors usually occur in the young age group. The other possibility of seminoma can be a seminoma. So I will
See, 1 second. Look here again. What happened here and here? Both are of the same process.
Okay, so I just want to look at the prostate. I cannot see the prostate here. Yeah, it's very small. So I want to check the same area in the axial images because the previous axial images was only at the scrotal region.
Check.
Can I have?
Take that.
Which one is axial post contrast? Okay, so
give me a differential diagnosis, my doctor.
Like seminoma, lymphoma are my differential in this case. Plus, I'm just looking at
okay, see
rectum.
how could the seminoma? Oh, leave the mouse 1 second. Leave.
Okay.
See, this is the testis here. How could the seminoma spread like this, okay, without any infiltration of the skin here, at least, okay, just along the cord, and it is very non-bulky, just enhanced, okay,
Yeah.
and okay, and coming here, and then causing a huge seminal vesicle here, see?
Yeah.
Is there are any other idea? Any other
So
cause?
it can be an infective etiology.
Yes, like what? What is
Like
one of the most common infective etiology in the genitourinary?
the fournier gangrene, but I cannot see
No.
any air foci.
No. What else? Something come from the chest.
Yeah, tuberculosis.
Excellent. Okay.
Okay.
Okay. So this is a genitourinary tuberculosis. Why is this not tumor? Why? Because see, tumor, if I suppose this is tumor, at least this is aggressive process. Okay. Then what happened? It must enlarge, and infiltrate everything here and here and everything. It will not just affect the scrotal wall and then stop and then go along the cord. See, only along the cord, and then from the cord to the seminal vesicle. This is, see, a selective process. So my colleague, in any selective process like this, both infection before tumoral. Okay? Infection.
Okay.
What
Thank
happened? This is a very difficult case, by the way. What happened? A target infective microorganism targets the genital system. Target what? Target the seminal vesicle, then prostate. Okay, see the prostate. See?
Yeah.
Then the testis.
Yeah.
Okay.
Okay.
Thank you, doctor,
Okay.
so
Thank you,
much.
doctor.
It was a very difficult case. This is a TB of the male genital system. Next candidate, my colleague.
Yes, hi, doctor.
Hi. Doctor, you have some noises, please. Hello?
Hello, can you hear me now?
Yes, much better. See my colleague again and again. Hopefully, I'm planning to do another 6-day, the next week. Hopefully, I can for all candidates, October and non-October candidate, but this is next week. Second, tomorrow will be morning because I have some emergency. So session of tomorrow will be at morning for me, but for you it will be like at 1:30 p.m. Okay, or 2:30. I will text at the group. 50. Ask control doctor, please, if you can.
Sorry, could you please score for me, doctor?
Okay, 50-year-old female patient presented with right iliac fossa pain for 3 years.
3 years, okay.
Sorry. For
3 weeks.
3 weeks, sorry.
Okay.
The end,
There's
the end of the day.
So, okay, I'm presented with an axial cuts of CT abdomen pelvis with contrast for a patient presented with right iliac fossa pain. I would like to scroll the images, then I will give my comment. Okay. Okay, I can see that there is fat stranding seen within the right pelvis with this is a soft tissue lesion. I'm not really sure. Could you, doctor, could you please scroll more upward? Yeah, okay, this is the uterus, and I can see that there's a right adnexial complex lesion with peripheral enhancing wall and central multilocular low densities. I'm suspecting this is a complex right adnexial lesion, so I would like to check in the coronal view.
This is the coronal view.
Yeah, this is okay. This is the uterus, and the right adnexial lesion is noted again. There's no free ascites. The lesion looks multilocular. There's no free ascites, just fat strandings noted surrounding the lesion. So in this case, I'm suspecting that this might be tubular lesion, tubo-ovarian or tubo-ovarian abscess.
Okay.
So I would like to see the rest of the images, and I would like to yes, the left adnexia looks fine and the uterus looks fine. So I would like to confirm my findings by doing transvaginal ultrasound. And I would like to send the patient for urgent gynecological referral.
Okay. See here. What is this? This.
Where?
This.
Sorry, I can't see your cursor.
What is this? Look, concentrate with this.
Oh, this is a vein. This is a vein. This is a thrombosis in the vein, I think. Thrombosed vein, right?
Again. Look, follow it. Look, where is it terminate?
Terminate within the lesion.
No, tubular structure terminate here. What is this?
Okay, this is appendix. This is the cecum, and this is the appendix. Noted.
Yes.
Okay.
So give me a diagnosis.
So this is appendicitis, maybe appendicitis and causing pelvic inflammation as well.
Or it may be a tubo-ovarian abscess
or
associated
ovarian
with
abscess associated, yeah, vice versa, yeah.
Reactive appendicitis, correct? Correct?
Yes, doctor. Yeah,
Okay,
correct.
thank you, doctor, so much. This is,
Thank you,
see my colleague, right adnexial complex peripheral enhanced lesion. So it is a tubo-ovarian abscess, first of all. Then look here, you must exclude appendicitis. It may be the cause. This is the appendix, by the way. How we differentiate or locate the appendix? As I told you before, this is the ascending column, this one. See? From the descending column. This is the descending column. Go down, step by step, step by step, step by step. See here, this is, see. This is the ileum, terminal ileum, okay? This is the valve, ileocecal valve. Look here, concentrate here. You must pick up a tubular structure, this one. See, my colleague, this one. This one. Okay, tubular structure originate from the posterior aspect of the ileocecal junction. Okay, down, then we go down. This is a tubo-ovarian abscess and the biosalpinx. See, because this is tubular structure is communicated with this one. Okay, look here, much better here. See my colleague, this one. biosalpinx surrounded the tubo-ovarian abscess associated with reactive appendicitis. That means, sorry, I was indicated wrongly. This is the tubo-ovarian abscess, my colleague, sorry. Okay. And where is the dilated? This one, this is the biosalpinx. What happened first? The tubo-ovarian abscess, and then it caused a reactive appendicitis. Next candidate. Hello?
Assalamu alaikum, sir.
Assalam. Request control, please.
Sir, I cannot see the button today where the
Okay.
request is there. If you can please.
Okay. 25-year-old female patient presented with pelvic pain and irregular menses.
These are sagittal T2 weighted MR image in a 25 years old female who presented with irregular menstruation, in which I can appreciate that there are cystic areas seen posterior to the uterus, in which I can appreciate a layering and a fluid level with hypointensity and ranging from hypo to hyperintensity, suggesting of T2 shading sign. There is also a tubular structure adjacent to it, which is showing
Excellent.
hyperintensity on the on its superior aspect. So I believe that this is likely arising from adnexal origin involving the tube. And I would like to confirm the signals on the T1 weighted image to see that whether it is hematosalpinx or it is simple hydrosalpinx. On the T1 weighted images, I can appreciate that there are bilateral posterior adnexal masses which are showing hyperintense signals. They are medially, the medial part of both lesions are touching each other and are abutting the posterior wall of the uterus as well. They are giving a ultrasound equivalence of kissing sign and the MR. And there is also a layering seen in the left-sided images, and the uterus is normally visualized. And sir, I would like to see sagittal T2 once again to look for deep-seated endometriosis.
See, doctor, look
In
here. What happened here?
So these are bilateral kissing ovarian endometriomas with tethering, and they are
Excellent.
there's a hematosalpinx bilaterally, and the
Okay.
uterus is pushed together, and they are all giving a fibrotic type appearance with the posterior wall of the uterus and both medial wall of the ovaries being showing adhesions.
So, what
There's
is the name
also
of this sign?
this is the kissing ovaries sign of
Okay.
deep-seated
And what
endometrioma.
else? What else?
Uh,
Clover leaf
Clover
sign.
leaves.
So, give me your final diagnosis.
Uh, these are bilateral ovarian endometriotic cyst with hematosalpinx,
Okay.
giving rise to clover leaf sign and kissing ovaries. I would refer the patient to gynecological MDT for further management.
Thank you, doctor, so much. This is deep infiltrating endometriosis. Look here. The sigmoid colon is adherent to the uterus due to fibrosis. Okay, my colleague. And this is hemorrhage, okay, with fluid level. And this is dilated tubular structure. This one, okay, containing blood. So this is hemosalpinx. Thank you, doctor, so much. Next candidate. Next candidate. Hello.
Candidate 12 is not responding. I will take his place. I'm 13.
Okay. Hello, Dr. Nagam.
Yes, welcome.
My colleague, I'd like to greet our superstar, Dr. Nagam, because this is, I think, the fourth session, the continuous, consecutive sessions that she arranged. Thank you,
Thank you
Dr.
so
Nagam,
much.
so much, really. Really, I appreciate your effort. Thank you.
With pleasure, with pleasure.
Okay,
You are doing the great job, in fact.
thank you. 25-year-old female patient presented with lower abdominal pain and swelling. She has a history of laparoscopic treatment for ectopic pregnancy. Would you request
Okay,
control? Can you request
okay,
control?
fine. Fine, come on. Okay, just would you kindly repeat the history for me?
Again, thank you for this question. And it is better for you if you didn't pick up what the examiner said or you forget something, ask him. He will not be sad, really. And yeah, overall, it is better than make a mistake. Better asking for or requesting a new repetition than making a mistake. 25-year-old female patient with lower abdominal pain and swelling. She has history of laparoscopic treatment of ectopic pregnancy.
Okay, so I
Go
have been
on.
provided with an MRI of the pelvis of a 25-year-old lady presented with lower abdominal pain post-intervention. I would like to have a general look before starting my comments. It's not scrolling, although I requested the scroll.
Yes, yes. Use the arrow.
Also, no changes, not moving.
I will scroll for you. Okay.
Okay, fine. So this is sagittal T2 sequence, fat sensitive. I can see that there is an abnormal soft tissue swelling at the region of the fundus of the uterus with
Yes.
abnormal small high T2 signal foci.
Yes.
I would like to check the other sequences to look for the transitional zone.
What is the
Rest of
location?
the
You didn't tell me about the location and some anatomical characterization.
Of the uterus. Okay.
Yeah.
It is
See,
retroverted.
see. You talking about which one?
الاسبوعين اللي فاتوا ندير الاسبوع لهم بيرتاحوا
One
بيرتاح
second.
زوجهم ما اتخذ القرار بيتخذوا ان شاء الله.
Hello. Hello, دكتورة نغم. Hello. دكتورة نغم. Can you hear me, please? Unmute yourself, please. دكتورة نغم. دكتورة نغم, unmute yourself. Hello. Okay, طب next candidate. We lost دكتورة نغم. Hello.
السلام عليكم sir.
عليكم السلام. Request control, please.
Okay, sir. Request.
You know the history?
Yes, sir.
Okay, go on.
I'm not able to scroll.
Use the arrow. Yes.
Yes.
Go on.
I'm provided with the T2 sagittal images of the MRI, in which I can appreciate lobulated soft tissue intensity, mass, which is low on T1, and it is adjacent to the uterine fundus, and superiorly it is reaching up to the level of umbilicus. It has surrounding perilesional fat standing, and it is somewhat inseparable from the adjacent. It is abutting the adjacent bowel lobes. Uterus
Yes.
is antevated and normal size. There is an indentation at the inferior aspect of the uterus, likely due to previous C-section scar. Endometrial thickness is of normal size. No uterine mass appreciated. Junctional zone is well preserved. Cervix and vaginal structures are normal. I would like to see the axial post-contrast and the field weighted images to further comment on my findings.
Okay. This is, you want to axial? This is axial.
This is the T2 axial images. Redemonstration of the lesion which I described. Redemonstration of the lesion which I described previously, which is low. Sir, I can't able to move. Low intensity lesion, which is attached anteriorly to attached to the anterior abdominal wall muscles up to the level of umbilicus, and posteriorly this lesion is attached to the dome of the urinary bladder with surrounding fat stranding.
Okay,
Both
where is
ovaries appears
where
on
is
the muscle.
see, where is exactly the lesion?
Okay. So this
Where?
is the lesion basically.
Okay. Describe the extension.
This is the lobulated lesion, which is seen
Yes.
in the interior, lower interior abdominal wall and in the pelvic cavity. The lesion is low intensity on T2 weighted images. It is interiorly adherent to the interior abdominal wall muscles, like these are rectus abdomini. And posteriorly, on sagittal images, it seems to be inseparable from the uterine fundus. There is surrounding perilesional fat stranding, and rest of the structures appears normal. I would like to see the post-contrast images to enhancement of this lesion. It seems neoplastic to me, likely malignant, and the extension of this lesion is at the anatomical location of the uterus, so it can be malignant process, likely rectal adenocarcinoma, but I would like to confirm on the post-contrast images to see its enhancement.
Okay. What else? Look here. What type of carcinoma do you expect here?
It's adenocarcinoma.
Okay. What is the expected location here?
Sir, it's likely at the site of the uterus because it has communication with
Okay.
the urinary bladder fundus and the umbilicus.
Okay. What else? This patient just has a laparoscopic gynecological operation. What else can happen here? See, it is by the way a very good answer. It is aggressive mass, looks like malignant, but here see, this is a loop not infiltrated at all by this large mass. What else
Yes.
could be this mass?
So it,
And
if I
see,
want
one
to see the
second,
post-contrast, okay.
1 second. This is the umbilicus. There are a fistula
Yes.
tract or a connection at the site of the endoscopy. Why?
Okay. So it can be an ectopic endometriotic tissue.
What else? What else? Post-operative. What is the
Post-operative
most
collection. Post-operative collection.
excellent or post-operative? What else?
Abscess formation.
Excellent. Infection. Like this, you enumerate everything. And even if you didn't reach the definite diagnosis, no problem. But at least you are in the correct pathway. What is the correct pathway? This is an aggressive lesion where in the dome of the bladder extending to the umbilicus, but it has collection inside. Number one, it may be a Aracus carcinoma. Number two, maybe sarcoma, no problem. Number three, it may be infection due to the laparoscopic instrumentation. And by the way, this is infection, actinomycosis. Okay, actinomycosis. But see, doctor, you are right. You are correct. Many cases in Viva is a case for differential diagnosis. Okay, thank you, doctor,
Sir,
so
if I
much.
give the differential of neoplasm, it is correct or considered incorrect?
Very, very correct. Why the first diagnosis for this case was a neoplasm. Even in the
Okay, sir.
radiopedia, they tell a long history. First, they suspect malignancy, then they take biopsy, then like this, and finally they was surprised it was actinomycosis. Thank you, doctor, so much.
Okay, thank you.
Doctor,
Thank you. Thank you.
welcome. Dr. Anagam, could you return back?
Yes, sir.
Welcome. Another case. Could
Okay,
you,
now history.
1 second. This patient has dyspnea.
Okay, so I'm presented with a frontal chest radiograph of an adult patient who presented with dyspnea. I can see that there is a large opacity projected over the right lung, middle and lower zones. It appears
Okay.
lobulated,
Okay.
well demarcated,
Okay.
no other focal
What's your differential
lesion.
for this? What's your differential for this?
It could be infection, pneumonia, it could be neoplastic
Okay.
process, lung cancer.
What is this? What is
Okay,
this?
I would like. This is a
What is this?
portacat.
So, what is
Portacat.
this?
So he is a oncology patient, and this is most likely
Okay. So
lung mass.
first comment on the lines. Where is the
Yes.
portacat here? Is this the correct
Okay.
position? Is this the correct
Portacat.
position? Looks like
I think it is
where?
lower. It should be in the
Yes.
what the table mentioned.
It should be reduced or recorrect, anything, or
Yes,
retrieval.
readjusted. Yes.
Okay. What will you do? What is your next step?
Okay, if this is the first presentation for the patient, then I would like to proceed for cross-sectional imaging, CT scan of the chest with IV contrast. Okay, so this is an axial CT images of the chest with IV contrast along mediastinal window. There are multiple soft tissue heterogeneous enhancing lesions involving both lungs, the largest in the right lower zone corresponding to the X-ray finding. These lesions show no calcification. I would like to look for other associated symptoms. There is a large filling defect in the left atrium.
Excellent.
Could be representing a thrombus or
you
tumor.
risk see, 1 second. You risk yourself. Sometimes our colleague, most of us, take too much time describing in a very obvious lesion. Okay? And forget this big disaster. Okay, tell me.
Okay. Okay. So the lung lesions could be representing metastatic processes, and the left atrial filling defect could be representing a blunt thrombus or a tumoral thrombus. Looking for mediastinal lymph nodes, I cannot detect any lymphadenopathy. I would like to check for pulmonary emboli.
What will you do next?
Okay, after I would recommend echocardiogram.
What else?
I would like to check for the enhancement of this lesion. I would like to look for the extension of this thrombus into the other pulmonary arterial tree. Lung window, bone window.
You told me this looks like metastasis. So what is your next step?
Okay, I would complete the staging for the abdomen and the pelvis. I would like to check for mammogram if the patient is a male, sorry. Lung metastases, then I would like to...
He's not a male. He is not a male, by the way. This is a female.
Okay, so I would like to include breast imaging. Okay, this is an MRI, cardiac MR. Okay, dynamic study. The ceiling defect is protruding through the valve into the left ventricle. I can see faint enhancement inside. I would suggest could be a tumoral thrombus.
Okay. What happened?
Yes.
See, what happened here? What happened here?
Abnormal high signal intensities on the bilateral white matter of the temporoparietal regions, as well as the occipital on the right.
Mm-hmm.
Okay.
Tell me, see, Dr. Nagam and all my colleagues, my advice for you in very long case like this, and I think this new Viva system must include some cases like this multimodality. Try to describe in very short bullet and tell the differential. Tell what happened. What happened here? What is this? Patient
Okay.
has atrial thrombus, and then I give you this brain. What should you tell me?
Okay, so
What is
I'm
this?
looking for signs of brain infarction and metastasis. These are high T1 signal.
That
Yes,
this is
abnormal high
flare.
T.
This is flare,
Okay,
not
okay.
one. See, one
Okay.
second. How to differentiate between flare and the T1?
By the white matter, it's much more dark on the flare.
Yes. Okay.
Yes.
What happened
Okay.
here? What happened?
Infarction.
Okay.
A
What do you
thalamic
wanted to say?
infarct.
Okay. Where is the infarction exactly? Where?
Okay, on the right thalamus, basal ganglia,
Okay. What else?
and internal capsule.
What else? What about this? This, all of this?
Yes, yes. It is
So,
all abnormal high signal, yes.
see,
So showering emboli.
excellent. I'm waiting from this one. Do you know if you see this one and you told me, oh, doctor, this is a brain of the same patient showing multiple territory high signal. It looks like it is scattered all over the brain, more at the left. So it looks like a showering emboli. Thank you so much. In 1.5 minutes. Okay.
Okay.
See my colleague here. See 1, 2, 3, and here along the MCA and the PCA here. Okay, so there are showering emboli. Till now we didn't pick up the primary. What will you do?
I will complete my staging, CT neck, CT abdomen pelvis, bone scan, mammography.
Do better to do a PET CT.
Okay, fine.
I don't know, we have maybe a connection problem. Okay. This is the PET CT. What happened? Tell me.
Okay. So there is abnormal avid lesion in the sigmoid colon. Highly likely, yes.
Avid uptake or increased SUV.
FDG, okay.
Okay. SUV.
Standard
uptake value. Okay. SUV.
Okay.
Where?
In the sigmoid colon, most likely to be the primary lesion, I would like to advise for colonoscopy, biopsy, histopathology, and to refer for MDT meeting discussion and follow-up.
Thank you, doctor, so much. It was a very long
Thank
case.
you.
By the way, this patient has a history of resection of uterine sarcoma and 2 years ago. And this is a local recurrence here. This is a local recurrence of the uterine sarcoma, which looks like a colonic malignancy. Anyway, this is the primary, and the primary cause what you said, what you see along the previous examination. Okay? The most important here, the X-ray. If we didn't talk about it, it is a mistake. If we didn't take care, look it, we will talk about it as infection, whatever. We'll go in the wrong pathway. Okay?
Okay.
Then,
Thank you.
Then here, welcome. This is the CT. You did very well when you pick up this embolism or thrombus, whatever. Here. Okay, and if you remark it is connected, look here, it's connected with the
أيوة.
tumor.
Yes.
Tumor connected. Okay, and it has
Yes.
some enhancement here, fin. So it is a malignant thrombosis, causing showering to the brain. Thank you, doctor, so much. Do we have any candidate?
Yes, sir. I'm 15, candidate 15.
15. Request 1 second. Request control.
Sir, I have requested remote control.
Okay. Thirty-year-old female patient presented with a severe abdominal pain. Go on.
Okay, these are fat sat T1 weighted contrast enhanced MRI images of a patient
Look
having
T1 better. Better T1.
I can see a complex
Yes.
complex T1 low intensity lesion in the placed in the cul-de-sac. It is surrounded by the capsule, and I'm trying to look its. I'm trying to find its exact location. It could be from the ovary, or however I would like.
What sequence do you want? What sequence?
T2 sagittal if available. Yeah, and the coronal. Okay, yeah. I can appreciate that the visualized structure is likely enlarged, is actually the enlarged right ovary. And there are multiple peripherally arranged follicles with increased central stoma. And yeah, this was opposite. Yeah, this is the most of them show internal isointensities, suggesting internal hemorrhage. There is small amount of fluid in the surroundings of tissue. So my principal diagnosis in this is likely a right ovarian torsion. However, I would like to see its cause of the ovarian torsion. Stir, yeah, a coronal may be better. Contrast enhanced coronal study. So it is the uterus is somewhat pushed towards the this lesion. Right over here, I'm suspecting some abnormality in the pedicle.
Okay. So your final diagnosis?
So this is a case of a right ovarian torsion surrounded by small amount of fluid, and this is the pedicle. I can see enhancement of its parts.
Yes.
So as the emergency, I will pick up my phone and inform the referring physician will suggest referral to the gynecology for urgent management in this case. Thank you.
Why you can detect some enhancement in the torsion? Why?
Because due to engorgement of the vessels, the pedicle is still vascularized. So it is
another cause. I mentioned the cause in the beginning of today's session. How many blood supply of the uterus? 1 or 2 of the ovary?
It is a dual blood supply. It has a dual blood supply from the uterine,
okay.
From the ovarian.
Okay, thank you, doctor, so much. Do we have any candidate from the list?
Yes, we skipped candidate 10. He's coming now.
Candidate 10 is here?
Yes, sir, I'm here. Yes.
Request control, please, doctor.
Sir, I'm unable to request outside.
Okay. This patient has a 35-year-old female patient presented with a history of infertility.
Okay, sir. Sir, I'm provided with hysterosalpingogram. Contrast is seen.
Yes.
Sir, contrast is seen to manage to pass through the uterus. which is of its normal size and is also seen outlining the right as well as left fallopian tube. I can appreciate some small irregular filling defects identified within the uterine cavity,
Okay. Okay.
which are seem to be consistent with in all images. And also, I can appreciate there's a free spillage of contrast on the right side, but on the left side, I don't
Okay.
appreciate spillage on left. So considering
Okay.
the previous history of like DNC, I'm considering some adhesions within the uterine cavity.
Okay.
And also there is a non-spillage of contrast on the left side, which also need to be evaluated. And apart from this, I can see more images.
Yes.
Lateral or
All the same. What's your diagnosis here,
okay.
doctor? What's your diagnosis?
Some additions, so most probably there are some psyche or additions within the endometrial cavity.
Excellent. What is the name of this disease?
Sir, usually it's in the tuberculosis and and
No.
also post-surgical and post. Yes, sir. Yes, sir. So it's usually the due to maybe post-surgical as well as sometimes post-surgical Asherman syndrome, which is. Hello. Hello. Yes, sir. Sir, hear me?
Yes, yes. Go on.
Okay, sir. Sir, yes, sir. Sir, this is Asherman's syndrome, and it's most likely some post-surgical as well. In TB as well, we have found this type of addition, but the cavity
Excellent.
is normal, but
Yeah,
they
yeah,
persistent defects.
yeah. Yes, this is adhesion due to Asherman syndrome. Asherman syndrome caused by extensive or aggressive cartilage of the uterus. Okay, there are filling defect due to the synechia or adhesions, and there are irregularity hair.
Yes, yes, yes.
Besides that, there are blockage of the left tube.
Yes.
Thank you, doctor, so much. Thank you, or all of you, my colleagues. Tomorrow we'll meet. I will text at the group either 1:30 or 2:30 Indian time. I will text. Thank you. Have a nice day. For tomorrow, our colleagues, trust in yourself. All of you really, really did very well. You did all your best. You did make a great effort. Hopefully, God will be with you. I hope all of you, be calm. Don't worry, even if you missed any case, no problem. No one goes the Viva without make one mistake, two mistake. All of us did mistakes. This is acceptable. Okay. So if you lost something or you feel that you didn't make well, you didn't perform well in one case, don't worry at all. Okay. The passing or non-passing of Viva is for all over the performance. Thank you very much for all of you. I hope you all of you my best wishes.